Silent seminar before. I don't know about you, but we'll give it a go. Well done for making the 8 a.m. slot. Excellent. Full marks. We're here to talk about how we shift from the current disjointed siloed model of community health care to fully integrated community health care, and we've got a great panel to talk about that. I'm Julian Hartley, Chief Exec NHS Providers, and I think probably now more than ever, we all get a sense of how important community services are. Perhaps they haven't had the profile and importance accorded to them that they really deserve. But I think now there's a real recognition of the importance of community services in the context of health inequalities, of serving patients in the right place, of making sure that the integration between local authority work, not just social care, but education and the wider determinants of health, as well as obviously the key interface between mental health and acute services. So we've got a great panel to kind of take us through some of the challenges, opportunities and innovations that are happening. And I'm going to ask the panel, if you would, to just introduce yourselves before we get into the conversation.
Good morning, and yes, well done for getting here for 8 o'clock. I'm Mairead McCormick, and I am the Chief Exec of Kent Community Trust, predominantly covering the east and west of Kent.
So good morning, everybody. I'm Matthew Bryant. I'm Chief Executive at Dorset County and Dorset Healthcare Trusts.
I'm Katrina Percy from the National Association of Primary Care, and I tend to spend my life in this space now around neighbourhood care. Previously a Chief Executive for 10 years of a community and mental health trust.
Fantastic. Thank you, panel. So what we're going to do is we're going to allow each of the panel members 5 minutes or so to sort of outline their thoughts, and then an opportunity for all of you to get involved in the conversation, pose your questions, comments, reflections on what you've heard. Sound okay? Good stuff? Okay, great. So I think, Gethin, you're kicking us off.
Lovely, thank you, and morning, everybody. I was going to start a little bit with the perspective from Wales, recognising that Wales is set up differently, and talk a little bit about the health board model, how that supports the join-up of care, or how it should enable the join-up of care. So for those of you that aren't aware, in Wales we have 7 health boards. They are the single entity that is responsible for commissioning of service, the provision of service, and holds the statutory responsibility for public health. So all of that is joined together in a single organisation under that single leadership. A big part of our role as the health board is the commissioning of primary care services. So that's general practice, community optometry, dental services, and within the area that I serve, we have an exceptionally deprived population in the old mining valleys of South Wales. So a really 450,000 population with some of the most deprived wards, certainly within Wales, but in fact some of them are the most deprived within Europe. We've spent a large amount of our time as a health board really understanding our population, and we're really fortunate because of the internal public health approach. We've got we've stratified our whole population. So every adult within Cwm Taf Morgannwg has now been stratified. That is individualised data that's shared with the GP. We as the health board have a broader definition of that. We don't see the individual patient detail, but it allows us to use that to understand what our services need to look like. The other benefit in terms of that is that we've started to use it a little bit. It's a daunting challenge for our cluster teams. Sorry, we call them clusters in Wales. We can't call them the same as in England. So we call them clusters. You would know them as PCNs. So we have to have it different. So we've started using that at a micro level. So actually every practice now is working out their advanced care plans for their top 50 patients. So, you know, doing that, it's been a really lovely way into how to begin to understand the data, understand your population at a practice level, and how do we begin to use that in those conversations with the community teams. The second bit, and this is where we're looking at how do we begin to coordinate, and we've got a huge public health time bomb in Wales, particularly with diabetes, but the associated challenges. So it is really much about how we're using that through carousel clinic models to really think about that proactive planning for those patients. And the third bit of being the health board that's really helpful is we're doing all the direct commissioning then as well with third sector partners and really ensuring that we can embed that. So, you know, the bit though that I think is the most effective is having public health embedded within our function as a health board. So just very briefly, you know, our focus, we've had lots of initiatives in Wales over the last few years of a little bit of this and a little bit of that and associated money, and what we've ended up with is a complete hodgepodge. So our primary sort of focus at the moment is pulling that back now and moving back to a single team around a registered population with a range of functions, but very much seeing that central team around that cluster. We're very fortunate our clusters really sit around natural communities of care. I think that's a really important aspect. There is a lot of history in the South Wales valleys. You know, if you live in Merthyr, you don't want anything to do with the people in Aberdare. You know, and it's a really it's a long history, and so that gives us that opportunity to shape those teams. There is a national programme within Wales, the ACD programme, the Accelerated Cluster Development, and that gives us some of that framework, but the challenge is that it's become very much about task and delivery of some things, rather than stepping back and thinking, how do you develop the team, how do you create that focus, and bring that through. I think the other challenge we have in Wales is digitally we're behind the curve compared to England. Having worked in England for 20 odd years, coming back into Wales, digitally we're really poor, and we've not adopted technology in the same way. We've got little pockets, but that is fundamental to how we can coordinate and drive that join up of care. And I guess the other piece, and the take-home piece, I think for me from when I've done this in England and now in Wales is creating that leadership capacity and that focus and that time at that team level and at that senior level. You know, as the Chief Operating Officer, I clearly spend a little bit of time sorting out ambulances and EDs and planned care recovery, but I really do try and carve out at least 2 days a week focused on this agenda, and I think that's really crucial. And it's great because I can just decide what I'm moving, and I don't have to talk to anyone else. So I guess the three take homes from Wales would be the population health strategy piece is key, and using that to begin to unlock and bring in people in understanding what we can do differently for our populations. It's engaging that in those smaller pieces, and I think the big bit is that nurturing of team. We've got to remember we're bringing people together that haven't worked together, and just instructing them to work as a team isn't going to help. So we've done a lot of work with the NAPC. They've helped us with a programme of engagement with those teams and driving that. So I'll stop there.
Gethin, thank you very much. That's great introduction, and good to hear actually. I don't think we hear often enough about work going on in Wales, so thank you. Great, so next to you, Mairead.
Yes. So I started in post about 15 months ago, and I suppose it's always good to think about what gets you out of bed in the morning, and we're talking about inequalities. And one of the most striking things for me when I first started in the job was to recognise that the life expectancy if you're born in Thanet, which is in East Kent, is 17 years less than if you're born in Tunbridge Wells in West Kent. And I was so shocked by that. I was so stunned. Now, I travel between both on a weekly basis, and it's actually palpable. The second thing that was really significant was the head count of GPs per population. So it's the lowest in Thanet pretty much in the country. So the challenges in East Kent are very different to the West Kent. And I guess the third thing is, you know, the question that's been posed, how do you move from this siloed working to a much more integrated model? Having been round to visit the teams and understanding where they're coming from, one of the first things that I noticed from some of our core groups was, we used to work like that, and then we were centralised and pulled apart. And the noise that I was hearing from the GPs, just give us back our practice nurses or our district nursing, is very real, because I think what they're actually saying is, please give us the skill set to manage our local populations. That's what they're really saying in translation. So we've got lots of good stuff to go on. And I think I'm just going to focus on the practical stuff. For me, it's about how do you get the boots on the ground doing what they need to do and enable them to do that. And I think it's really, first of all, taking time to understand what the community is. And I don't get wrapped up in, is it a PCN, is it a locality, because it's really important that all of our partners are around the table. And my experience is, if you sit down with the right people, they'll describe your community for you and start there and then work out from there. And I think the second thing is, this is a really practical thing, but it's really important. You've got to get the time in the diaries and absolutely expect that clinical workloads will tail off on the days that you're putting your teams together, and plan for it. It's real, they need the time, and they need the time to sit together to design what they need to do. And you've got to afford that time. I think the second thing is, with our teams, one of the things that was really practical and helpful was to supply them with the right information that they recognize, their own data played back. Let's try and understand what this looks like. What are we trying to solve? And collectively look at that information together, so you've got that sort of one version of the truth. The other thing I thought was really practical is, what we done is we mapped out all of the estate, and we're starting to play back to our teams. This is all your local estate, and I'm not just talking about health estate, I'm talking about working with the district councils, the local authority estate. Put it on a map and show them, this is yours. Where I really want to get to is for all of us to give permission for that to be used freely and no cross-charging. So it's a big step, and it's going to involve trust building and people working together, but we're getting there and nudging it in the right direction. Provide people a nice environment to create these teams and to be away from the sort of the drone of work, because I think that nice environment says we value what you've got to say, and we really want to listen to what you need to do, what do we need to do to enable you. I would encourage socialising, of course I would. I would encourage socialising, because actually this is about building relationships, isn't it? You get the relationships right, everything else falls from that. The thing that I'm really passionate about, and the NAPC are going to help us with this engagement piece, is how do you get the resources as close to the decision makers as possible? And I am absolutely up for just being the payroll at the end, if that's all we are as a provider, and everything else gets devolved down, because if we're going to trust these teams to do what they need to pull off, then they're going to need that resource allocated and given the responsibility. And then I think be clear about what you're expecting as outcomes and get people to describe what they think good looks like. And then I think just finally, in parallel, work out upfront what you're going to have to compromise on. Because I think if you work out what you're going to have to and you will have to compromise, then you can start mitigating that in the background. I'll give you an example of that. EPR systems drive me absolutely nuts. And it feels as if we're not the customer, and actually it's the wrong way round. Well, if an EPR system works for that PCN or that locality, let them get on with it. We've got to work out how to unravel the mess of reports and et cetera, et cetera. This is about the right information, the visibility of it, and the teams having that at their fingertips. To ask people to enter data onto 2 or 3 systems is not acceptable. And if the systems are still not talking to each other, move away from one and get onto the right one. And then finally, I think it's really important that we start developing integrated leaders for the future. So most of us will have grown up in sort of either health or care or the voluntary sector or primary care. So I'd really like to start now, and we're just developing an MBA for integrated leadership where you go through all domains and learn, because actually the only way I learned was speaking to colleagues in the other sectors. I think we need to start training people now. So joint training and development, big advocate for it, and I'll stop there.
Fantastic, thanks very much, Mairead. And I mean, really quite, I think I could see people's reactions when you were describing the difference between Thanet and Tunbridge Wells. Extraordinary, stark health inequalities, and great to hear about the work that you're doing to kind of address that. So let's move on to you, Matthew.
Great, thank you. And if it's all right, I'm going to stand up because I feel out on a limb. I think this is the closest I might ever get to a silent disco. So I hope you can hear me. And I think what you've heard from colleagues is great. And for me, what Mairead covered, those things about understand your population, have an asset-based approach, be prepared to give up control, measure what you're doing, and thinking about leadership. If there's a template to do this, those are the things. So I'll just talk a little bit about what we're doing in Dorset and actually maybe some of the behaviours that are needed to support this change. So in Dorset, I'm chief exec of 2 very different trusts. So the DGH based in Dorchester, which is a small DGH serving a highly rural area, and the quite big Community and Mental Health Trust, which works across the whole of the integrated care system and covers 2 very different local authority places. One's urban and one's highly rural. And I guess what we're trying to do in terms of our ambition is we are seeking to work in a federated way, really with the aim of bringing to life the ambitions for population health across the system. So we believe with partners that we can be the leading agent of change. And previously I also worked in Somerset, and it's great to see some of the SFT team here today, where we brought together mental health community and acute services in one trust that also runs a significant amount of primary care. And I suppose for me the context that we're doing this work in is really important. I think this context is not unique to the NHS, it's actually shared by many healthcare systems in the developed world. But I think we're in the middle of 3 revolutions in healthcare at the moment. And the first of those is a demographic revolution that's causing a real resource gap in how you pay for healthcare, how you get the workforce for healthcare. It's not often that West Dorset leads the way in cultural trends, but in terms of demography, we are leading the way, and nearly 1/3 of our population is over 65 now, compared to 18% of the average in England. The second revolution I think we're experiencing is an organisational revolution. So I've been in the NHS for about 25 years. I came in at the end of what I would describe as managed systems, the old strong health authority structure that was in place with public health being central. The 2000s was the era of the strong organisation, the FTs. And now it's a different era. It's the era of collaboration, of coming together, of partnership. And that's a very different skill set. It needs different conversations at board. And the third revolution, I think we're only just beginning, is the revolution in terms of the relationship between the citizen and health. So we know we need to move from being a caregiver to being a care partner. We need to move from empowered professionals to empowered patients. And actually this, if we can harness the potential, is the most powerful self-care tool in history, but we don't really use it very much. And in this area of community services, it's got its greatest potential. So we've got lots of examples of work going on in Dorset that we're doing together by taking an asset-based one-team approach without boundaries, by bringing in our experts by experience, the patient, the service user voice, by seeking different partnerships. We're changing our frailty models. We're changing our diabetes models, where together we can create a new open door 7-day-a-week service. We've got great examples of bringing mental health and physical health together in the sphere of chronic pain. And in research, I think we've got what is the UK's only community-based research hub for vaccine research, where an acute and community provider are coming together, and it's co-located with vaccine delivery, and we've put it in one of our most deprived areas in Dorset. So we've got lots of work going on, but you'll all have your own examples. So I just want to leave you with a couple of thoughts about how, in terms of what this means in a change of mindset. And you might say these things are obvious, but I think with boards they're quite difficult to do. So one of the lessons I have from my lived experience is the importance of the conversation at board about what your core purpose is. So is your core purpose to run your organisation very well and to take responsibility for your bit of NHS and social care, or is your core purpose to actually take leadership for the wider population? Where do those things come into conflict? What do you really do when the chips are down? And that's quite a big journey of change for boards. It's been a big journey of change for me as a leader. I think I'm in a very different place to the place I would have been in 10 or 12 years ago. The second thing I would say that's really important, and Mairead touched on this in terms of inequalities, is how do you find the voices that you really need to hear, and how do you act on what you hear and work with those voices in a different way, whether they are about making different partnerships right at the heart of your communities, or for us working with primary care in a fundamentally different way. And I believe that's got to be based on very local conversations, and what we've got to do is to trust those local voices, and with QI methodology use that to create those new solutions. And the final thought I would leave you with is a thought about stewardship. So some of you may know the work of Muir Gray, who's kind of a great long-standing public health specialist and champion of activity in older age. And Muir Gray talks about our responsibility as leaders for stewardship. So the idea that we're holding something in trust, we're taking it and leaving it in a better condition. And as part of this, he also says, if we screw up the NHS, there won't be another one. And I think that idea is incredibly important for boards. What we've got, the things that we hold, they're not our assets. We are looking after them. And we have to have a different discussion with communities about their future. So we're applying this, for example, to community hospitals, where traditionally it's been a very binary discussion about, do you open them, do you close them? Do you have a fight with the local community or don't you? How do you play the politics? And we're trying to reframe this to say that these are actually the assets of the community. They existed before the NHS. Many of them will be in existence for a long time in the future. We will be clear on what we can run and what we can't in terms of modern models of care, but actually we're inviting the community in, and we've got some great examples of this, where we've now got networks of things running from our community hospitals that are making a real difference in terms of the wider determinants of health and bringing mental health and physical health services together. And I think for me then, for a board, that creates almost a virtuous paradox, that by giving up some control, you're able to run a better organisation and you improve population health at the same time.
Matthew, thank you for that. Some really thought-provoking reflections in there, particularly I think that point about the third revolution of the citizen and health, and then what you were describing about the core purpose of boards, in the way addressing the core purpose of whether the organisation's there to be run well or take leadership to the wider population. I'm sure we'll explore some of that in the conversation. Thank you. So Katrina, great to have you, and really good to have NAPC convening and many colleagues from that. So over to you.
Thank you. I'm feeling the pressure now, having listened to these guys, and you're going through your notes thinking, oh, quick, they've said that. So I totally agree with everything I've heard so far. Just as I was getting a coffee earlier, somebody who's in the audience said to me, so what's the 3 steps that you would go through to get rid of these silos and create integrated teams that are able to tackle health inequalities, population health needs? So I've done a bit of reframing and I'm going to give you my thoughts. We work across the whole country in this space, places that are really struggling, through to the sort of examples that you're hearing, and I'm sure many of you in the audience who are really taking this on. But just to start, I mean, we've done a really good job, haven't we, particularly in the NHS, of creating silos. You know, somewhere over here did a virtual ward. That looked like a great idea. So a pot of money came, separate from all of the rest of community services and primary care, and we created a virtual ward. Oh, they did a hospital at home. That was a great idea. Let's put some money and we'll have a hospital at home team. Oh, home first, that's a good concept. Let's have another team that does home first. And let's be honest, we have led, well-meaningly, because they're all good concept, sticking plaster solutions all over the place that make it frankly impossible for anyone in the primary community care space to navigate, let alone secondary care, let alone the people who are actually using those services. So what do we need to do about it? The first thing is, as the rest of the panel have said, you actually need to know who is in your team. What are the skills that, all of those nice names, but actually what are the skills that we've got in the team and how can we work better together? And we need to know which community responsible. This is not, let's have a really slick team, but it's hidden behind a single point of access, so it's totally anonymous. And if you need physio, you've got to go through that single point of access. Oh, you didn't need physio, go back, you needed OT. Go through another single point of access, or community nursing. We've all got it. I used to have services like that, I'll be very honest. So building integrated teams that they know who are in those teams, not a label of service, but what are the skills that can better meet their population. And I wholeheartedly agree with the point Gethin was making. We're very good in the NHS, they must be 50,000, we can't go smaller than that. Well, actually, I live in a community that's 4,000. Okay, we've got a lot of community assets. What we need to be doing is working with what people recognise as their community, not what we think is convenient lines on the map, or what the local authority even have put convenient lines on the map, or PCNs. So I think the first thing, point 1 on my 3-step, is the teams need to know each other. So they actually need to know the names of the people in the teams, not you can get them through an anonymous point, and we have to build them through natural communities. The second thing is, the way that the culture's been in the NHS for many years, those teams are going to need investment to enable them to flourish. So what's the budget that's generally cut all over the place? It's any investment in team development, organisational development, culture change, leadership development at the front line. Let's be honest, when the money pressures come on, that is the first thing that often gets cut. All the research would tell you that's what we need to invest in. So I think having the courage to genuinely put proper investment into giving those teams the headspace that Mairead and Matthew talked about, but also the facilitation to help them accelerate how they operate as a team. We've created a lot of barriers, and in theory in Wales it's a lot easier. We've created a lot of barriers that I think we need to challenge ourselves about, you know, but we have to run those processes because it keeps the the patient safe, those processes we've created for regulation. We've created lots of governance to keep the the patient safe. Let's be honest about what we've created, and I think Matthew talked a lot about that challenge that we have in how you are judged around a very top-down structure at the moment. Regulation looks at your bit. If your bit's all right, sod the rest of them. You know, I proudly hear Trust Chief Execs say, well, we've always balanced the budget, sod the rest of the system that's absolutely stuffed. I think GP business models is a challenge, but it's often an excuse. It's not as much a challenge. And most of the place I work, back in Hampshire when I worked there, working with the LMC, 50% of general practice were happy to move on from independent contractor status, and I've been out 8 years. The pressure that's come on general practice, most colleagues, when you genuinely talk to them about what they care about in general practice, it isn't my business model, it's about doing better for their patients. So I think that that's often an excuse, and I think actually it's one of our challenges, is until we've got it all lined up and it's all perfect, or maybe we'll do a pilot, that gets in the way. And then I think the final piece I would suggest is how we measure success. And we've moved so far away from someone like Michael Westwork. I work with colleagues who work across all sectors, not just health, they work in all industries. And the single factor that measures success against whether it is quality, customer satisfaction, shareholder value, if you're in a big commercial company, or quality and safety, we all know it comes in Michael West's work, is actually the trust and relationships and how effectively your teams are working, high-performing, flourishing teams. So actually, if we were really brave, that's the only thing we'd actually need to measure, because if they were clear about what success is, then they deliver it by being a flourishing, high-performing team, and it's very measurable. You can measure that. Now, we're probably not going to get away with that in health, but we absolutely, as my colleagues have said, need to move on from these very top-down performance management to creating a permissive culture with clear outcomes, or sometimes proxy outputs that measure success, but investing in how you create those flourishing teams. And I think that's the leadership challenge. How do you go from where we've been to these teams knowing how they are, allowing them to flourish within a permissive culture? And that's going to take bravery that I'm sure exists in a lot of this room to move and have the courage to go into that type of space. Thank you.
Fantastic. Trina, thanks very much. Great 3-step prescription for addressing the silo mentality. That's great. So, it is your turn, and you've hopefully stimulated and thought-provoking observations from each of our panellists. So, if you don't mind, could you say who you are, where you're from, just in terms of when you ask a question, and I'm sure our panel will be delighted to sort of respond to your questions, reflections, challenges, observations. So let's get going. Who'd like to kick off? John.
Hi, I'm an ex-chief exec for a secondary care organisation, currently a non-exec director for a couple of secondary care organisations and a GP federation. Absolutely brilliant set of observations there. They've answered most of the questions I had prior to coming to this, but I'm just fascinated by, given how primary care is funded, how do we shift the debate that I'm currently having with my colleagues from contractual debates to one of transformation? I'm really struggling to sort of get them to focus on that, because that's really why I got involved in sort of the primary care organisation, to try and facilitate that integration across those boundaries, but I'm coming up against sort of all sorts of barriers.
Thanks, John. Who'd like to have a go at that?
I should start.
Go for it.
I'll try and start. Yes, so I absolutely recognise it, John. It's a really difficult one. I guess my experience of working with primary care is that one of the greatest challenges is actually workforce, as it is for many of us. And I think a way into this is to demonstrate that actually this comes with an offer of people. And I think with the people comes an extensive skill set, and that resource collectively together it's taken us away from the contractual conversations into what can we collectively do if we put our workforce together. I think the second part of that is the conversations that I've been having is, because there was a very real threat between, is this community trying to take over primary care? All of that stuff goes on, doesn't it, all the time? And I said, look, I don't want to get into that conversation, because actually the answer is no. What I'm trying to do is get us to a place where we're working collective together for better outcomes. But if we want to get into that conversation, what would you like me to do? What is my role in this as a community provider? And if the end point is that you don't need me, well, that's great. But actually, can we work through what we think the end point might look like, and what are the natural steps to get in there? And I think one of the things that we're grappling with is, what do you need to do at a macro level right across, almost at the interface? Is it just being the payroll because of agenda for change, etc.? Is it more than that? Could we do learning and development, the training aspect? Can we do the onboarding, the recruitment? What are the functional things we could do at a macro level? And we're getting to a place that there's an openness for a provider collaborative. Now, that is tricky to navigate, and we're very much in the early stages of it, but that provider collaboration is a very real thing, that if we collectively put our resources together, what will we put them towards? What is the central function? And that's as far as we've got. So yeah, not without its challenges, but I think the workforce thing is a way in there because you're giving something. There's an offer on the table. It sort of almost distracts from the busy, it gives people headspace.
I was going to say that one of the very practical things we did back in our days in Hampshire is we basically underwrote the GP income. So as a big provider, turned over towards £500 million, so we could afford to do it. And we basically guaranteed that if they came into this integrated model, we would guarantee their personal income wasn't going to go down, which freed them up to be able to put their resources, as Mairead described, into the pot. And I think there's lots of solutions to the governance in the end. If you keep independent contractors or they come into an employed model, there's lots of different solutions, flowing the primary and community money through together. But I do think there's practical things like saying, we will underwrite, as a big trust, we'll underwrite that your income is not going to get affected, your personal income, if you put the resources in the way Mairead described.
Great, thank you. I think I saw, Giles, did you have your hand?
Thank you. Giles York from Sussex, and Matthew, absolutely, if you've got an ageing population, their parents are still in Sussex at the moment with what we're going through. I've worked in collaboration for many, many years, and I think it's very similar to integration. My experience is it takes longer, it's bleeding hard work, and it'd be a lot easier if the other people weren't involved. I was just wondering what your quick elevator pitch is, because you all talked about having clear outcomes and being clear what about it is. What is it that's so compelling that makes this hard work really justifiable?
Well, okay, so I think what is compelling, I go back to my context. So what's compelling is if we don't do it, the current model of provision is not sustainable and will fall over, is falling over. I think also there is so much potential to be released here. You've only got to sit down with frontline teams and listen to their frustrations, their thoughts, the suggestions of what could work differently that would make a real difference. Those are echoed by patients and families. And I think coming back to your description of this, it's a real challenge for organisations to know when to lead and to know when to follow. And I think in this space, taking that decision to follow, that actually we can give up this control, we don't need to be in charge of everything, is a really important part of this partnership working.
Great, thank you. Peter.
Thank you. Peter Gill from East Dorset, who's a neighbour to the east. And thanks, Matthew. I just wanted to come back on the observation you made about the board's purpose in the conflict. I thought that was just that's quintessential for the dilemma that I think we face. I've worked on 4 boards, all acute hospitals, realising that I might be the common factor this now, so I get that, but I've never observed a board that's been able to do the second of those 2 things. I'm just, for the greater good, if you like, rather than only serve what it thinks is its purpose and keeping the organisation safe. And I'm not sure I'm seeing that change. And I guess, well, one sort of example that kind of hammers this home to me is that University Hospitals Dorset, I'm told, is the biggest fracture neck of femur repair shop in the country, which at the moment we think is a badge of honour because of our size and scale, etc. I think it's a badge of shame that we are the worst falls prevention area in the country. And prosecuting that conversation is unpopular, put it that way. So I guess my question is, what ingredients need to be there for boards to reject the kind of programming that we've had for all our lives, which is, these are your targets, this is your constitutional raison d'etre, this is your legal duty, etc., therefore that's what you do. Because that grips us like a vice.
I was going to say I couldn't agree more. If you were to ask what's the biggest barrier I see across the country, it's people who are, if I were to be rude, king of castle of their organisation, and that's the accolade and the role that they've sort of worked to, and that you are rewarded for keeping your organisation safe. There are examples I see around the country, and you've heard from them, that take a very different type of leadership. So I think it is going to take recruitment of leaders that are wanting to work in this new space. The other observation I have is people put proper investment into the very senior leadership bit as well as the frontline leadership in terms of the trust and relationship. So when I've spent some time in Dorset or I spent some time in Kent, the guys here, you really see that investment in building relationships and trust. And I see it coming now out of UHD as well with Siobhan. So, but I think people have to commit to that. And just linking it back, this isn't bums on seats meetings discussing governance and partnership. And I think when I was in the NHS, I thought it was a bit of a rebel and that I didn't spend much of my time doing those pointless things. And then I look back from outside and I'm embarrassed by how much time I spent doing that. And when I look at observe around the country, if we're really honest, how much time are we in those really hard work meetings, as I said from the back, that feels really tricky, discussing what's the governance, what's the partnership agreement we're going to have as a bum on seat in a room? Oh, we didn't have that partner, better start again and get that partner in, rather than actually enabling some change to happen at the front line. And I think that then leads to change at a senior leadership level, because you create that permissive culture here, you can create it there.
Fantastic.
So it's lovely to see you this morning, Peter. I think it's really tough. The regulatory environment that we're in doesn't always enable that behaviour. I think the work that NHS providers does to challenge and help develop that is really important. But the kind of fundamental thing I would say is we talk about values-based leadership, and values-based leadership isn't kind of fluffy and being nice. It's using those values to guide us and keep us in the right place through very difficult issues and guide us to the right point in decisions. So it's tough for boards, and I think this conversation needs to be at the heart of board development. You know, some of the traditional skills that are needed in boards need to be left behind. Sometimes that needs change of NEDs and executive directors, and we need to think about how we get the board in the right place to deliver our ambitions around population health.
Fantastic. Thank you very much. I want to bring us in on time, so it is time. Can I just say a huge thank you to the panel. Great conversation. Just to say that we, as NHS providers, we're very interested in this agenda and have a thriving community network. Miriam's at the back there, if any of you want to go and have a chat with Miriam. Mary as well, who's involved in the work and leading that network. And just to reinforce the partnership as well in terms of primary care and NAPC, I think this is a topic that we'll return to more and more and will drive some of the changes that will be described. So I hope this early morning session has been worth getting out of bed for. It's been great to see you all. Have a really good day. We've got an exciting day ahead, but what a great way to start. So thank you to you all. Thank you to the panel.